Hi, everyone. Welcome to today's program about anti-MAG peripheral neuropathy. We're really excited to welcome Dr. Rich Lewis with us as our guest speaker about this very interesting and extremely complex topic. My name is Lindsay Colbert. I am the Executive Director at the Foundation for Peripheral Neuropathy, and I just want to thank all of you for attending today's session and also everyone who might be joining later. Before we get started, just wanted to do a bit of housekeeping. We are recording this presentation and it will get shared with you likely by tomorrow and also uploaded to our website for future viewing. If you have any questions at any time during this session, we will try our best to answer them at the end during our Q&A session. Feel free to type them into the questions box on your dashboard and we will try to answer as many as possible, noting that we prefer to only answer those that are general in nature and not anything that's specifically targeted for any personal medical advice. And lastly, if you are having trouble with the audio, please use your phone to dial in. Those instructions can be seen through the email that you received in order to gain access to the session. And now I am pleased to introduce Dr. Richard Lewis, who is joining us today. He is the director of the electromyography lab in the Department of Neurology and co-director of the neuromuscular clinic at Cedars-Sinai in California. Before joining Cedars-Sinai, Dr. Lewis served as vice chief of neurology and director of clinical neurophysiology at Harper University Hospital in Detroit. He was professor and associate chair of neurology at Wayne State University School of Medicine, where he directed the Hiller Amyotrophic Lateral Sclerosis Center. He was also co-director of the Muscular Dystrophy Association Clinic at Detroit Medical Center and director of the Inflammatory Neuropathy Center of Excellence. Dr. Lewis is widely known as a leading physician and scientist specializing in inflammatory and inherited disorders that attack nerves. He studies ways to improve diagnostic testing and patient evaluation standards and has been active throughout his career in educational, scientific, and advocacy groups for patients suffering from many different complex diseases, including ALS and Guillain-Barré syndrome. He actually is best known for the discovery and exploration of an autoimmune disorder that bears his name, Lewis-Sumner syndrome, which is a rare disease that attacks the insulation around nerves and causes progressive weakness, tingling, and pain that usually begin in the hands and arms. So without further ado, I'm pleased to officially welcome Dr. Lewis. He is going to be talking today, as I mentioned, about anti-MAG peripheral neuropathy, and we are so lucky to have him today. So again, Dr. Lewis, thank you so much, and it's all yours.
Thank you, Lindsay. I'm delighted to be here. This is a topic that is near and dear to my heart, but it is a complicated one. And so I apologize to those of you who are quite sophisticated about this, because I'm going to start with relative basics, just to put in the framework of understanding what these paraproteins are and in relationship to other things in our blood. So let me see, hold on, let me see if I can. There we go. It's a little bit. So what we're going to discuss is what are paraproteins, what are some neuropathies that are related to them, what is MAG, which is myelin-associated glycoprotein, how do the antibodies against MAG cause disease, and what treatments are available for anti-MAG neuropathy, and potentially what's available in the future. So to get started, the plasma proteins, or the paraproteins, are abnormalities of proteins that come in your blood. But there's lots of protein in your blood, and I thought we should at least get a feel for where these lie. So the major protein in your blood is albumin, which are basically what we call egg whites when we eat eggs. And you can see that that covers about 50% of the plasma proteins. And albumin is really a crucial aspect of our blood plasma because it carries hormones, vitamins, lipids, has relationship to medications we take, and also kind of controls to some extent the ability to keep our fluids within our bloodstream and not have them seep out into tissue. So when someone gets edema sometimes, it can be because they have very low albumin in their blood, and so the fluid or water content of the blood seeps into the skin tissue and subcutaneous tissue. Globulins, which we're going to talk more about, are the next largest component, and they cover about 40% of the plasma proteins. And they also carry lipids and hormones, but crucially, they're very important in the immune system. And then there are some other ones which account for about 10%, including some enzymes, hormones, and clotting factors that are not part of the globulin or albumin component. And so when you donate blood, they will take your blood cells and give red blood cells to people who are anemic. They'll give platelets to people who have low on platelets and are not clotting well. And they'll use the albumin for some people. And then they'll also use portions of the globulins. And if you've ever gotten IVIG, it's from this globulin component of 10,000 blood donors that can contrive the IVIG that you're getting. So within the gamma globulin component, and this is on this square here, I don't know if you can see my tracer, but in this rectangle is basically a cartoon of a serum protein electrophoresis. And you can see this gamma globulin portion is at the very end, and you can see it is kind of a round kind of hill as opposed to the peak of the albumin here. But within this gamma globulin component, there are multiple components which we call immunoglobulins. So there's IgG, there's IgA, there's IgM, which is an important one for you if you have anti-Magneropathy. There's IgK and IgE. And then these immunoglobulins are the things that make the antibodies that control infections and disrupt your immune system. So you can see that the major immunoglobulin is IgG, which is the fourth one down on the list. And that one has different components, and they act differently. It crosses the placenta, which means people who have mothers who have IgG disorders can sometimes pass a transient disorder to their infant. So one of the classic ones is Myasthenia Gravis, which is an IgG-related disorder. Some infants will have a transient 3 to 4 week myasthenia symptom from their mother's antibodies, but it doesn't turn into a disease because they end up making their own antibodies, which are not necessarily disease-related. The other ones you can see here, and each of them have their own importance, but the one we're going to talk a lot about is IgM. So this is a cartoon of an immunoglobulin. There's a heavy chain, which is this, if you look at the Y, it's the, this arm of the Y, and then there's the two arms here, which are the light chains. And within the light chains, there's a variable region, and these light chains are the ones that identify connect to the antigen and cause the antibodies. So there's a variable region here, and you can see this is where the antigen binding site is. So when they see something that they want to attach to, this is what's looking at it. So there has to be some stoichiometric kind of structural thing that looks like they can connect. So if the antigen has like these are cartoons, but you need something that's going to fit with this triangular part here. This one would be more round. This one would be more, peg related. So these variable regions are the keys to it. And these are the light chains. Some of the light chains are kappa, and some of them are lambda. So, and they each have different importance. For instance, in Anti-Magneropathy, the paraprotein is usually 99% of the time an IgM kappa paraprotein. So the kappa identifies the light chain, the IgM tells us which immunoglobulin class the problem is. We'll talk a little bit more about kappa and lambda light chains in a second. So the immune system is very complicated, and I'm not going to try to explain it all. But the best way to think about it, just simplistically, is there's cell-mediated immunity with T cells, and there's humoral or antibody-mediated disease, which is from the B cells and the plasma cells. And they talk to each other, and they relate, and there are antigen-presenting cells in the T cells that will present the antigen to the B cell, who will connect to it. There are B cells, and there's a whole evolution of cell changes that occur. And we're going to talk a lot about B cells because you've probably heard about the treatment with Rituximab. They work on B cells. But memory B cells, which also turn into plasma cells, they don't get affected because they've already memorized their antigen, and knocking out the B cells before it doesn't do any good. So here is the evolution of to go from the stem cells in the bone marrow to the B cell evolution. And here's these memory B cells, and you can see sometimes they can get targeted by the rituximab, which is a CD20 antibody. But the plasma cells, which are the ones that present that attack the antigens, are not impacted by the B cells, B cell inhibition. So you need different treatments for plasma cells than you do for things that come from the B cells. And you can see that some B cells will have antibodies that will work on antigens, but a lot of them, particularly the IgG ones, come from the plasma cell. And if you can, I'm sorry, let me go back a little bit. Down at the bottom of this slide, you can see some of these other medications that have an effect. So bortezomib is a proteasome inhibitor, and it works on a larger range of these evolving B cells and plasma cells. So IgM, primarily B cells, are circulating and are made in the lymph tissue, where the IgG-mediated immunoglobulins are made primarily by the plasma cells in the bone marrow. And so you can see that different treatments have to attack different areas, not just different cells. So what are paraproteins? Paraproteins are monoclonal, and I'll explain that in a second, immunoglobulin fragments or intact immunoglobulins produced by a certain clone, that's not clone, but a malignant clone of plasma cells or B cells. So if you remember this nice, smooth gamma globulin region here, a paraprotein will be like a spike within that gamma globulin. And if you take this gamma globulin and you divide it into IgG and IgA and IgM, that spike in the serum protein electrophoresis will be in if it's an IgM paraprotein, it'll be in the IgM sector of the gamma globulin. If it's an IgG, it will be in the IgG. A monoclonal gammopathy of uncertain significance, or what they call, abbreviate to MGUS, is a small amount of paraprotein. A large amount of paraprotein, such as this spike here, would be seen in a malignant situation. So the MGUS is basically a benign condition. The levels of the paraprotein tend to be low. And depending on if it's an IgG, there's a low level of abnormal plasma cells or a low level of abnormal B cells for the IgM. And then when the hematologists look at it, they do bone marrow biopsies, and there are no indicators of active or malignant disease. All patients who develop multiple myeloma once had an IgG or an IgA, usually, paraprotein or MGUS. But only a fifth of patients with MGUS will eventually develop myeloma. And the usual risk of progression is considered to be about 1% per year. So I send almost all, if not all, my patients with MGUS to a hematologist to, one, determine whether they actually have active myeloma at the time, and two, to follow them, and they determine whether they need to be seen yearly or every 2 years. I tend to recommend people be seen yearly by a hematologist. And the hematologist and oncologist can monitor the patient for the MGUS. And having seen many of these patients over many years, if you follow the amount of their paraprotein, and there's two ways to do that, it tends to grow over time. So if someone has an IgM MGUS with a level of 200 IgM in, say, 1975, in 1980 it could be 300, in 1985 it could be 400, and it gradually increases until the patient develops a malignant transformation where it's very high. So we just can follow the quantitative immunoglobulins, or in a serum protein, we can actually look at the mini monoclonal spike, which is the abnormal clone within that population of immunoglobulins. So MGUS patients may not need to be treated. And in general, in anti-Magneropathy, there are two different drivers for treatment. One driver could be that their neuropathy is severe enough, bothersome enough, that the patient and the neuropathy doctor feels they should be treated. And the alternative approach is the neuropathy doesn't necessarily need to be treated, but the patient and the hematologist and oncologist feel that the hematologic situation is significant enough that it requires treatment. So that's why I always work with a hematology oncologist when I'm thinking about treating a patient with anti-MAG neuropathy or other paraprotein neuropathies. So I've hinted at least that there are differences between IgG and IgA paraproteins and their significance versus an IgM paraprotein. IgG and IgA paraproteins are the ones that would be associated with multiple myeloma, a disease of the plasma cells in the bone marrow. An IgM malignancy is usually something in the lymphatic tissue and is called Waldenstrom's macroglobulinemia. There are also some other milder malignant forms, lymphoplasmacytomas, which can be seen with the IgM paraproteins. And there's what we used to consider completely benign, actually can be kind of a low-grade malignancy. So IgG monoclonal gammopathies, if we take 100 people over the age of 60 and just check their immunofixation electrophoresis or their serum protein electrophoresis, 5% of those patients, 5 out of 100, will have an abnormal IgG paraprotein or MGUS. If you follow them long enough, 20% of them may become malignant over 20 years or 10 years. So it's important, it's nice to know that, but many of those patients will have no real malignancy or medical problem from that for their entire lifetime. So the IgG is the most common MGUS or paraprotein. But if you look at that group, if you take 100 patients with an IgG paraprotein or MGUS, only a few of them have a neuropathy that are considered associated with it. Some of them could have diabetic neuropathy, some of them can have neuropathies of other cause. But when you look at it, the IgG is not related to neuropathy very frequently in someone who has an IgG paraprotein. The flip side of that is that patients with an IgM paraprotein, which is relatively uncommon compared to IgG, if you take 100 of those patients with IgM, over half of them will have an associated neuropathy. So it's not as common, but much stronger association with neuropathy. So when I see someone with neuropathy, I tend to get an immunofixation electrophoresis, and I'll explain that in a second, to see whether they may have something related to their neuropathy. My ears or my eyes or something perks up in me when they have an IgM paraprotein. An IgG kappa paraprotein, I'm less concerned about that's a relationship. So as I said, the light chains have some significance as well. When I see an IgM kappa paraprotein, then it's much more related to Anti-Magneropathy and neuropathy in general. An IgM lambda paraprotein has less of a direct association with neuropathy. When I see lambda light chains, however, in any circumstance, I get concerned for other disorders. One of them is what we call AL amyloid. Now, there's a genetic amyloid to transthyretin, which is a different type of amyloid disorder. Both of them cause neuropathy. Both of them can be very serious. The genetic form of amyloid neuropathy, patients were dying within 10 years because of severe neuropathy and also deposition into the heart and needed heart transplants. But we now have treatments for that. And excitingly, we're saving lives because of these treatments. So these amyloid neuropathies that are genetic, we now have some very, very strong treatments for it. It's been one of the most exciting things in my world in the last 10 years. The AL amyloid is more associated with myeloma. And so when we see lambda light chains, we very clearly get them to the hematologist and we look for myeloma. The other thing we look for is a disorder called POEMS, which is an abbreviation for polyneuropathy, getting big organomegaly, either the liver, the spleen, the pancreas, sometimes endocrinopathy like thyroid disease or diabetes, this monoclonal gammopathy, which is always a lambda light chain, and they can have skin lesions. And this is associated with changes in their bone, so they actually have some tumors in the bone, or a blood disease called Castleman syndrome. And you can test for a blood test called a vascular endothelial growth factor. And these patients with POEMS have extraordinarily high VEGF levels. And you can see some other criteria that can see. This was a deadly disease 20 years ago. And now with some modern oncologic treatments, including bone marrow transplant, these patients are surviving, living longer, and sometimes being cured. But it can be a very severe neuropathy. So when I see lambda light chains, the light bulb goes off, and I said they can have a bad disease, and I get them to hematologists. So getting closer to talking about MAG neuropathy, I apologize for the long introduction. But as I said, the IgM kappa is the one that's most associated. And the IgM kappa neuropathies are usually what we are associated with slow nerve conductions velocities on that nerve conduction test that you've had. And about half of these IgM kappa will have anti-MAG neuropathy. So the screening process is to look for the IgM kappa first, and then to see if those patients, do they have anti-MAG antibodies. Now, there are other antibodies that we know happen. There are ganglioside antibodies to something called GD1A and GD1B, which can have a similar neuropathy to anti-MAG. But the one we're going to talk about mostly is the anti-MAG neuropathy. And here's a little diagram of what I've already talked about in terms of when they have a lambda light chain. IgM lambda neuropathy may not be demyelinating or have slow nerve conductions and can behave differently than the anti-MAG or the IgM kappas. So you can see that this gets very complicated. And we in the neuropathy field and the hematology field are trying to get a handle on this. And so there is a study going on primarily in the Netherlands, but somewhat in the United States, called the IMAGINE study, which has been a little slow to get moving, but is being reactivated. And there was just a meeting of people on the IMAGINE study at the Peripheral Nerve Society meetings in Miami in May. So there is movement. We're trying to understand, of the people who have paraproteins, what is the IgM paraprotein neuropathy relationship, and how is anti-MAG different than some of the other ones? And it is a very confusing and complicated topic, and we need to enroll as many patients as possible to understand this. So what is myelin-associated glycoprotein? Well, it's a glycoprotein, which means a protein that also has a glycolipid component to it, and it's found within the myelin sheath and in the Schwann cell. So this is the myelin in this kind of salmon color. And up above it would be the Schwann cell that makes the myelin. And so myelin comes from the Schwann cell, which is the cell that connects to these axons. And as you know, peripheral nerves are basically like electric wires. There's wires, which are called the axons, and there's insulation, which we call the myelin. Now, myelin is more than just rubber insulation. There's a very active metabolic component to myelin. So it's not just insulation, but simplistically, from a conduction standpoint, that's what it does. And it keeps the electrical signal from seeping out of the axon, so you can have very fast conduction going from one node of Ranvier to another. But there are things that connect the myelin to the axon, and one of them that's part of this system is MAG. There's also these other components which we now know have antibodies associated with them, which are what we call nodal and paranodal neuropathies. But if you mess up this interaction between the myelin and the axon, you can get very severe conduction slowing, and sometimes the conduction will block. I should have put a video in here about conduction, but for the sake of time, I didn't have this, so we'll do it another time. So anti-MAG neuropathy has very specific blood tests, nerve conduction changes, and pathology. And the pathology that's associated with anti-MAG antibodies is that the myelin, which normally is tightly wound around the axon is now there's an opening, a widening of the spaces between the myelin. It's what we call widening of the myelin lamellae. There aren't many other disorders that do that. And if you look into an immunohistochemical stain for the IgM, you can actually see little IgM deposits on these myelin segments where the antibodies are being deposited on the myelin loops. And this widening of the myelin lamellae changes the conduction properties of the myelin and the axon, causing conduction changes, and will also damage the axon underneath it, so the axon gets destroyed. So that's the pathology of it. But what happens to people? So anti-Magneropathy actually has quite a variation in terms of manifestation. For those of you who are on the call and have anti-Magneropathy, if I ask 20 of you how it affects you, the majority are going to say one thing, but there's going to be a minority that's going to have a slightly different way the disorder seems to have presented to them. Most patients will have a very slow, insidious sensory disorder. So the first thing they'll notice is some numbness and tingling of their toes and feet. And it can take years, sometimes 10 or 20 years, before it actually affects balance and walking. It can affect the toes first, but sometimes the fingers and the toes can be impacted at the same time. And it tends to creep up the legs and hands in what we call a length-dependent fashion. The longest nerve fibers in your body are the ones that come from your lumbar spine down to your toes. So they can be 2 feet in length, or if you're an NBA basketball player, it could be 3 feet in length. But they're the longest nerve fibers we have. They are also the ones that can have more places for antibodies to attach to, which may be why the length is a significant aspect of why you manifest the disease. While most of the patients have predominantly, if not completely, sensory disorder, some people will have weakness of the hands and feet and will lose some of their muscle bulk, what we call atrophy. And why some people have more weakness than others is not known. So what does the neurologist find when we examine you? Well, the first thing is, depending on how severe it is, we look to see how drunk you are. So if you're walking with wide base, when we walk, one foot kind of goes almost directly in front of the other. But if I can see a space between your legs when you walk, then you're wide based and you may not be able to walk a straight line easily. There are many causes of ataxia. In the brain, the cerebellum is our balance area. And if someone had a cerebellar stroke or a genetic disorder of the cerebellum, they can equally look drunk. But in this instance, your ataxia is not from the cerebellum. It's from the fact that you're not getting good signals from your feet to keep your balance. And the way we know that is that if we ask you to put your feet together and keep your eyes open, most people are able to do that because our vision helps us with balance, as does our inner ear and our vestibular system, the inner ear to the brainstem. And as long as you have 2 of the 3 components working, the third component being what your signals from your feet are, things do okay. So if I take someone without neuropathy and ask them to close their eyes, they still have their feet working and their inner ear working, so they don't lose their balance. But if you have neuropathy and you can feel your feet, and you only have your vestibular system working, that's not enough to hold your balance, and you will tend to fall. The term we use in neurology is called an abnormal Romberg test, but it's a very good test to tell us whether your ataxic gait is from sensory disturbance. And then we test sensation, and the major component of the sensory exam that relates to the ataxia is vibration sense, when they put the tuning fork on your toes and ankles, and position sense, and particularly position sense. These are all from large diameter sensory fibers. Feeling pain and any burning pain, an abnormal feeling like you don't feel the hot sand on your feet, those are small diameter fibers, and they can be affected in this, but they don't affect your balance. Associated with this is that you lose your ankle reflexes, and sometimes everywhere, and your strength may or may not be reduced at your ankles. So part of the evaluation of someone with neuropathy, is the nerve conduction test. I'm sure the favorite thing that you get done to you when you have these neuropathies. But there's a very characteristic pattern of conduction changes, which was identified by a group that included my colleague Austin Sumner, which is that what you get is what we call distal accentuated slowing. So when they do the motor conduction studies, they stimulate the nerve, say at the wrist, and record the muscle in your hand, and then they'll stimulate the nerve at your elbow and record at the same place in your hand. And the time it takes from the stimulus to when the muscle responds is called a latency. And if it's on the stimulation at the wrist, it's called the distal latency. And the one that's from your elbow is called the proximal latency. The nerve conduction velocity is the distance from your wrist to the elbow divided by the latency difference between the distal latency and the proximal latency. So normally, nerve conduction velocities in the upper extremity, in your forearm, run around 50 meters per second to 70 meters per second. The distal latency tends to run between 3 and 4 milliseconds, a thousandth of a second. And the reason we don't talk about a velocity here is because the velocity to the muscle has many other components than just the nerve. It has delays at the nerve muscle junction, it has muscle fiber differences, and temperature is an issue. So we don't usually talk about a distal velocity. Actually, if we compute the distal velocity, it tends to run only about 40% of the nerve conduction velocity in the forearm, so 20 meters per second would be the distal velocity. But in anti-mag, this distal latency can be twice as slow as the conduction velocity. And we have ways to compute this to kind of show this. So this distal accentuated slowing is very characteristic of anti-Magneropathy, and is one of the few neuropathies that actually have this. Saying that, if you just had it in the median nerve, which is the nerve, the sensory, which is to the thumb, the muscles of the thumb pad of your thumb, and you wake up in the middle of the night with your hand asleep, this slowing of this distal latency with normal conduction velocity in the forearm is what we see in the common carpal tunnel syndrome. But in anti-Magneropathy, we don't just see it in the median nerve, we see it in the ulnar nerve, we see it in the nerves in the leg, we see it in virtually every nerve we test. So this distal accentuated slowing is a very key marker of an anti-Magneropathy. In addition, the sensory responses, we either can't find them or they're very reduced in amplitude. So what we do in the testing is we look for the IgM kappa paraprotein. If we do the serum protein electrophoresis, which shows us the albumin and the alpha globulins and some of these other globulins, besides it's not as specific, and we miss some of the paraproteins in those. And so most of us will do a serum immunofixation, which just looks at the gamma globulin fraction and is much more sensitive in finding these paraproteins. If we find this, we then do the anti-mag testing, which there's a screening test, and then if the screening test shows it up, then we do a specific Western blot to prove that it's anti-mag. Then what I do is I look for how much IgM there is. So if the IgM levels are less than 200, that's pretty normal. They may still have this MGUS, but it still says it's not a lot of IgM being made. If it's less than 500, well, I'm not as concerned, but when it gets over 800, that's really concerning that there's a malignancy. You can also look for what we call a mini monoclonal spike on the serum protein, and if we see it, that will tell us how much of the abnormal MGUS there is. The higher the mini monoclonal spike, the more serious it is. And as I said, I tend to refer these patients to hematologists, oncologists, and I use specific ones who are ones that concentrate in lymphomas or myeloma. So once we've identified that they have the paraprotein, that they have anti-mag antibody, that they have a neuropathy, and they have nerve conduction studies that look like anti-mag neuropathy, they become potentially patients who we can treat for anti-mag neuropathy. And as I said, sometimes we treat because the blood disorder is such that drives the treatment, and sometimes it's the neuropathy. And what treatments we use depends on various aspects. If the neuropathy is severe, we're going to be more aggressive. If the hematologic problem is malignant, we're going to be more aggressive. Because all treatments are basically determined by a balance of the risks that we take that you take by taking the medicine versus the potential that it's going to do some good. So what you're seeing here is basically that I'm not treating the neuropathy, I'm really treating the hematologic disorder. Because if I can reduce this MGUS, then I'm going to reduce the amount of bad stuff, the antibodies, and basically impact the neuropathy. So I think I've kind of gone over a lot of this, just to know that if you have pain, burning, stinging pain in your feet, buzzing that's really painful, there are neuropathic pain medicines. They're not going to treat the neuropathy. They just treat the painful symptoms. So the Neurantins and gabapentins and Lyricas and pregabalins and duloxetine and Cymbaltas and nortriptyline and Pamelor, those are symptom treatments for pain, but they don't treat your disease. The usual treatments for inflammatory neuropathies, the ones that are called CIDP, for chronic inflammatory demyelinating polyneuropathy, tend not to be effective in anti-mag neuropathy. It's not 100%, and there are reports of people responding to IVIG, usually not to steroids. But in general, that effect is not very strong or very long-lasting. So unfortunately, we don't have any proven treatment for anti-mag neuropathy, but we do have treatments that many of us believe work, and certainly if you can, the hematologists know that it works for their diseases, and so by inference work for the neuropathy. So there is no specific treatment for the anti-mag neuropathy unrelated to the hematologic. One of the leading scientists in the paraproteins in neuropathies had developed a potential treatment for the specific anti-MAG antibody, developed a company, worked on it. The approach was very encouraging in different cell models, but had to be stopped because of, as I recall, toxicity issues. And so we still don't have a treatment that just targets the anti-MAG antibody. Obviously, the more specific the target for your treatment, the less likely that it's going to be toxic in other ways. So a specific target for anti-MAG antibody would be potentially the safest treatment, but we don't have that yet. So most of you have probably been at least discussed about the use of rituximab and B-cell depletion. Since IgM paraproteins are made by B cells, or the pre-plasma cells, before the memory B cells, or before plasma cells for sure, B-cell depletion was thought to be a very important treatment. And actually, I may have been one of the first people to use this medicine back in 1995, I believe. The story is that I had a patient in Detroit who was a member at Oakland Hills Golf Course, and he said if I can cure his neuropathy, he would take me to Oakland Hills Golf Course, a very famous golf course, anytime I wanted. Well, after some consultation with some of my colleagues in Hopkins, we tried this treatment. I barely knew about it at the time. And sure enough, his neuropathy was basically put in remission for 10 or 12 years. He did take me to Oakland Hills Golf Course, which was lovely. I didn't go as often as he suggested, but so it worked for this patient. So we've tried using this in a number of patients, as have many groups around the world. And in these small, uncontrolled circumstances, many of us have found a significant number of patients, not everyone, that seem to respond. When you treat with rituximab, the circulating B cells, as identified by CD19, an antigen on the B cells, CD20 is the target for rituximab. CD19 is what we use to monitor how many B cells are circulating. The B cells go down very quickly within a week or so to less than 1% of what they should be. But they're not gone because they're still sequestered in lymph nodes, bone marrow, and other places, spleen. And so you're not getting rid of all the B cells. So it's not the strongest treatment in the world, but the fact that it's not as strong as some also makes it less toxic than some. So when you look at the IgM levels in these patients, they go down. So if it was 500 before the treatment, they can go to 400 and then 300 and then 200. And if you keep repeating the treatment, the B cells continue, the IgM levels continue to go down, and with it, the mini monoclonal spike. And at some level, when you get the IgM levels down enough, the neuropathy will usually stabilize and can improve. So we tend to treat every 6 months, and some patients after a while, every 9 months or 12 months, and we can monitor the B cell levels to determine. So that's kind of an approach to rituximab. There are more aggressive rituximab treatments. So for me, the IgM levels have been very helpful. Some of the studies suggest that anti-MAG levels are more helpful. I find them less sensitive for a variety of reasons. So I do look at both and we see which one works. And that tells me that there's a biologic effect of the treatment on the IgM paraprotein, but it doesn't tell me whether the neuropathy is improving. So that is dependent on what you tell me, on what my exam tells me, And at some point, I've done studies that show that the nerve conduction changes actually can improve as well. They don't get completely normal, but they move in the right direction. So to determine whether the treatment's working, I need your help, because it doesn't matter so much from a neuropathy standpoint if I say, oh yes, your vibration sense is improved. What you want is to see improvement in function, your quality of life to improve, and maybe your discomfort and other things to get better, which is impacting your quality of life. So we use formal outcome measures to determine this. We use some things that we ask you about, like quality of life scales or functional rating scales, and then we use some tests that may be able to help tell us whether you're improving or not. And sometimes you may say, nah, I don't think it's helping me very much. But I'll say, you know, it's very early in the game and I'm seeing that you're walking much better or a little bit better, or that you're doing a few things better than you thought you were doing before. And so let's give this more time. So why don't we have an FDA approved treatment for this? Well, there have been some clinical trials on anti-Magneropathy, and unfortunately, they never showed a benefit. And there's a long reason why small, uncontrolled trials seem to show benefit, including things that I've done and others, particularly in Italy and other places. And the formal, randomized, double-blind controlled studies didn't. Some of it has to do with the fact it's a slow, insidious disease, and it may take us time to show improvement, and the studies may not have looked long enough. It gets very expensive to keep looking for a year or 2 years later. Sensory disorders are very difficult to show effect. It's easy if you have a weak muscle that gets stronger. Motor problems are simple. They're kind of dumb. They either move or either your limb moves or it doesn't move. But sensory stuff is very complicated. It's a coordinated action of different diameter nerve fibers. And so it can be very difficult to ascertain improvement in disorders that are primarily sensory. The outcome measures used may not have been sensitive to change. They may need to do a longer treatment with more lowering of IgM levels. My own experience is I need to get those IgM levels down well below 400 to be effective. And so sometimes you need multiple treatments, but those studies did not do that. And some deficits may not be fixable. If you've had the disease for 20 years, there are aspects of your disease that are just not going to be fixable, even if we had the cure. And you can't always take that into account when you're recruiting patients. And it may be that it just was too slow and insidious, and we may not have had enough patients in the trials to see this statistical significance. So I've kind of gone maybe a little over. I'm going to go a little quick on this, but I'm going to ask you to think about this when you talk to your doctors. You need to recognize that you and I don't always talk the same language. What you're concerned about may not be what I think is the real big issue. And so you need to be very explicit about your worries, concerns, fears, and what is really troubling you. Will I have to be in a wheelchair is the unexpressed fear of every patient I see with neuropathy. None of them asked me that question, was a minority. And so I've learned to just tell patients, no, you'll never, you're going to walk the rest of your life. Same thing with shortening the life. And then there are issues about what's the long-term plan. Sometimes the doctor is more interested in the short term. Let's think about what we're going to do now than necessarily worrying about the long term, because until we know how we do in the short term, it may not be paid to worry about the long term, but I understand why you would want to know this. We need to give you realistic prognoses, and you and I need to be on the same page about what the treatments are going, what you should expect from the treatment in the early stages and in the long run. And lastly, we need to go over what risks and benefits are. Many patients equate side effects and risks. A side effect is, I give you a medicine, you get a headache, or you get nauseated, or you get sleepy, and you say, I don't like this, and you stop it. And within a day, usually, you're back to your old self, and you say, I didn't like that medicine, you don't take it anymore. No big deal, because it's only a minority of patients who have these side effects. Otherwise, it wouldn't be on the market. A risk is, I give you a medicine, you get a severe disease, and you either die or you're in the hospital and you're damaged for a long time. Risks are concerning. Side effects are not that concerning because you can stop the medicine and get rid of them. So we need to understand the variability of the problems in these neuropathies, and that's where IMAGINE study comes in. We need better outcome measures, and that's also part of the IMAGINE study. And once we do that, we need to develop more treatments, more specific for anti-MAG, and we need to develop new treatments for the paraprotein's that are less risky. The hematologists and oncologists have all kinds of treatments that can treat these paraproteins, but they all carry significant risks, and we have to decide when is the right time to treat. So on that note, I went the wrong way, sorry. I think I can stop. Thanks for listening. I hope that was helpful. I'm sorry I didn't leave a ton of time for questions, but hopefully a lot of them were answered in the talk.
Yeah, no, thank you so much, Dr. Lewis. It was extremely helpful. We are getting in a lot of questions, and I know we only have a few more minutes, so I'll try to see what we can cover, and anything else we'll follow up at a later time with specific individuals. You didn't really talk much about physical therapy or exercise. Do you have any thoughts specific to those that have anti-MAG?
Physical therapy and exercise are good. But they don't treat the disease. You're not going to overcome the disease with physical therapy or exercise, but you can maximize your function by physical therapy and exercise. It has a lot of benefits. Physical therapists can help you with your balance. They can talk to you about making sure you don't want to be falling. And I know people don't like using canes. I recommend walking sticks for many people because they're socially a bit more acceptable than canes. But you need to be able to keep yourself from falling, and physical therapists can help you with that. They can help you with your strength. So I think it's very good, but I think you need to have realistic expectations of what they're going to accomplish.
And do you have any thoughts about diet specific to those that are affected by anti-MAG?
There are all kinds of, and I don't mean to be cynical, but there are people take what they call immune diets and things that they think affect their immune system, and maybe they do. But to some extent in this, it's not that you're not immune deficient. You have a segment of your immune system that is overactive. So I'm not aware of any diet that is going to be particularly have a major impact on this specific disease you have. A healthy diet is good. I have no objections to one-a-day vitamins. If you want to take supplements, it's fine. Too much vitamin B6 can cause painful neuropathy. So I wouldn't do more than if you're going to do a one-a-day vitamin, I wouldn't do a B complex on top of it. It's just too much, particularly of B6. So I think there are supplements like alpha lipoic acid that help neuropathy pain. So my personal preference is to eat a healthy, balanced diet And if you want to take multivitamins with it, that's fine. Calcium and vitamin D is generally helpful, but not specifically for this.
And does MGUS show up in blood tests?
Yes.
Okay.
So the blood tests that show it is either a serum protein electrophoresis, but more sensitively a serum immunofixation electrophoresis. And whether it's an MGUS, which means it's a monoclonal gammopathy of unclear significance, usually meaning it's mild, or something that's showing up either myeloma or amyloid or Waldenstrom's that's more dangerous, is dependent on the company it keeps and how much of that paraprotein it is. But the blood tests show up. The way you screen for an MGUS or paraprotein is a serum immunofixation electrophoresis or a serum protein electrophoresis.
And you talked a lot about rituximab. Have you any additional information to share about IVIG when it comes to effective treatments for anti-MAG?
Yeah, as I said, in general, IVIG is only minimally effective, but there are patients who seem to have a response to it. It doesn't affect the paraprotein, so the IgM levels don't go down. The anti-MAG levels may or may not go down. It can work on the antibody itself, so at times it works, but in general, most patients have a modest or no effect of IVIG. So do I sometimes try it? Yes.
Sure.
But I don't have, I'm hopeful, but not necessarily optimistic that it's going to work.
And are there any specific signs that someone's symptoms or just the condition itself of anti-MAG is getting better or worse in a person?
Well, the worst, usually the thing that patients will recognize is that the numbness that may have began in the toes over a certain period of time, hopefully it's years, will go up to their ankles and then above the ankles. And then the hands may get it, maybe the fingertips, and then it goes to the wrist. That's the most clear-cut way people notice that my sensory symptoms are getting worse. Their balance may get worse. That would be another clue as to getting worse. And I've had patients who say my tingling and numbness was to the wrist, and now with my rituximab, it's only in the fingers, or it went from the mid calf to the ankle. Now, functionally, that may or may not have a major significance, but it helps me know that the treatment is on the right track.
Right. No, that's really interesting. And then I guess the last question is ultimately, is there anything else that you think a patient with anti-MAG should know? You had mentioned obviously the Imagine study, which is a great program right now for research. Is there anything either affiliated with that study or anything else that we should try to highlight before we close the session?
I think the highlight is to work with your clinicians. I do think if you have a paraprotein, by the way, there are occasional patients who have an anti-MAG antibody and not a paraprotein. So there are times that we'll do the anti-MAG blood testing, even though we don't find the paraprotein. It's pretty unusual, but it does happen. But basically, you want to make sure that you're working with a hematologist and a neurologist who is comfortable or knowledgeable about anti-MAG neuropathy. You know, within the scope of all neurology, neuropathy is a relatively small component, even though neuropathy, as the foundation will tell you, is probably one of the most common neurologic disorders. But neurologists tend to deal with strokes and seizures and other things in some ways more than neuropathy. And anti-MAG neuropathy is a small percentage of neuropathy. So it's sometimes useful to get to a center of excellence. And basically the GBS CIDP Foundation has centers of excellence. And the Foundation for Peripheral Neuropathy can also help you find a center that is knowledgeable in this. And it's worth having, at least at some point in your disease, someone who's quote unquote an expert see you to give you some advice, who can work with your neurologist, even if it's 1,000 miles away.
No, I think you hit the nail right on the head, Dr. Lewis. And to your point, for those that need to find a center of excellence or a neurologist that specializes in this type of research or this condition with respect to treatments and finding better ways to manage your symptoms, feel free to let us know. That's what we're here for. And again, I know there were a lot of questions that we didn't have time to answer. And for those, I'm very sorry. I encourage you to follow up with us through email, through phone. Check our website. We will be sure to share as much information as possible as we can as it becomes known, or help with specific questions. So again,
I'm happy to look at the questions, send my responses, and you can send them to the patient.
That would be great, Dr. Lewis. So we might just do that, and we can follow up accordingly. So again, thank you for that offer, Dr. Lewis. Thank you again for your time today. For those that are joining us live, thank you for doing so. For those that are watching this recording later on, as I said, feel free to reach out to us at any point if you have any questions. We're happy to help, whether it's regarding anti-MAG or any other cause of peripheral neuropathy. That is what our organization is here for, to help improve the lives of those living with this condition. But again, we ran out of time for that. I apologize, but it was a very enlightening conversation, very scientific, which was really exciting and intriguing for me personally. I know I learned a lot, and again, thank you so much.
I apologize for that, but
no,
on the other hand,
it's a tricky one.
To know where your problem lies within the normal functioning of the body. So
yeah, no, it is, and having those answers might might actually get more questions to come later on, but it's a good thing for patients and for caregivers that are trying their best to understand this condition and how to treat it and live their best life. So again, thank you everyone for joining. We really appreciate it, and have a good rest of your day, everyone. Again, thank you so much. Bye-bye.
Take care. Thank you.
Thank you.